Hello, everyone. Thank you so much for joining. My name is Jessica Reed. I'm the Quality Improvement Manager here at Maine Quality Counts. And on behalf of the Maine Lung Cancer Coalition, I'd like to welcome you all today to another webinar in our series. Truly, we are all working together to reduce lung cancer in Maine. The funding for the Maine Lung Cancer Coalition is from the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, and the Maine Economic Improvement Fund. So many thanks to our funders. Today, I am very excited to have Dr. Simon Craddock Lee with us, and he's going to be talking about scaling up lung cancer screening in the real world, navigating vulnerable patients. So just a few housekeeping slides as we get ready for this webinar. Audio lines for non-presenters are currently muted. Please use the chat box for any questions or comments. We have talked with Dr. Lee, and there'll be a couple of points in his presentation where he will be opening it up to questions. At that time, you can unmute yourself and ask that question, or again, you can put it in the chat box, and we will monitor the chat box and help him with those questions. Just to briefly mention now, if we have questions at the end and we don't have time to get to all of them, we will develop a question document, and we will follow up with Dr. Lee and get those questions that we may not have time answered back to all of you. If you're requesting CME for this webinar and you did not send into Zoom through a direct link for yourself, or if you're watching as part of a group, if you could please email us, or you can also put it in the chat box. So we will track that and make sure that we get the Survey Monkey, to you after the webinar for your CMEs. Maine Quality Counts is working to improve the health of everyone in Maine, and I know as we all work together around lung cancer screening, we hope to really impact that health. You can connect with us at mainequalitycounts.org and on various social media platforms below. So today, the speaker disclosure and for CME certificates, Dr. Lee, the speaker today, does not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this CME activity. Again, as I just mentioned, a CME evaluation survey will be sent to you all via email, and we ask that you please complete the survey within a week. Maybe a little over is fine too, and then a CME certificate will be mailed within 1 month of the completion of the survey. Typically, we turn that around in about 2 weeks, but we always like to say that. So again, thank you all so much for joining us. And again, a special thanks and welcome to Dr. Simon Craddock Lee. We are so excited to have him today. He is an associate professor and program co-leader for the Population Science and Cancer Control program for the Simons Comprehensive Cancer Center at UT Southwestern, joining us from Dallas, Texas. And we were just saying about the joys of technology to be able to do this today. Prior to be recruiting to Dallas, Dr. Lee was Cancer Prevention Fellow at the National Cancer Institute, NCI, and trained as a medical anthropologist. His implementation research focuses on the culture and organization of cancer screening and cancer survivorship in urban and rural safety net settings. Dr. Lee is MPI on an NCI award to improve care coordination for patients with multiple chronic conditions, also diagnosed with cancer, aka complex cancer survivors. Since 2012, Dr. Lee has led a mixed methods implementation study expanding rural breast cancer screening and patient navigation in 35 underserved countries in North Texas, supported by the Cancer Prevention and Research Institute of Texas. With this focus on care delivery, his studies include disease sites such as breast, colorectal, and lung cancers. Dr. Lee reviews for the National Science Foundation as well as NIH and has held various leadership positions in the American Anthropological Association since 2009. He is an elected fellow for the Society of Applied Anthropology. So as you can see, very accomplished, and we are, again, so glad that you can join us today. So at this point, I'm going to turn this webinar over to Dr. Lee, and he will begin sharing his slides and start this webinar for us all. Okay, Dr. Lee, we're all set for you to share.
Thanks. If I have now shared, there we go.
There you are, perfect.
We're okay with that, Jessica? Great.
Yes, looks great, thank you.
Thanks. So good afternoon, everyone. Greetings from Dallas, Texas. It's nice to be in touch with some folks from out of state, and I love the opportunity to be able to talk about some of the work that we're doing here. I'm really interested in trying to talk about, my understanding from the organizers was it was an opportunity to talk about scaling up lung cancer screening in the real world with a focus on navigating vulnerable patients. So my work here in Dallas is largely made possible by the Cancer Prevention and Research Institute of Texas. I am a co-principal investigator with a medical oncologist and colleague of mine, Dr. David Gerber, whom you may know is a thoracic medical oncologist and has been doing a lot of work in immunoprevention and therapy, but has a sort of really broad interest in trying to think about how we can work together with population science in bringing people in, because his largest concern is about early detection of lung cancer, obviously. And the opportunities with the approval of low-dose CT screening for lung cancer by USPSTF and then CMS gave us an opportunity to really bring this to a population level. And so what I want to talk about today is just to walk through how we have established low-dose CT as standard of care for screening in Dallas County. I'll talk a little bit about our setting and how that's enabled us to establish those new processes. And then I have data that we just presented at the World Congress on Lung Cancer in Toronto, which is a year-one look back in the referral rates and what our lung RADS outcomes have been for standard of care. I then want to talk a little bit about the key challenge for Dallas County when we look in contrast to the National Lung Screening Trial. What if our underserved patients need more help given the kind of evidence that we have that justified the guidelines? So I will talk about our randomized control trial of patient navigation in Dallas County, and some of the issues on the way in which our CT is tied to a sort of approach to pragmatic trials within a real-world setting. I want to then think about adaptations for different settings, given the kinds of models of navigation that range across the cancer literature, but I'm sure you'll be familiar with them in other disease contexts as well. And talk about our efforts to adapt what we've been doing in Dallas County on top of a rural screening program across North Texas in order to bring low-dose CT screening for our rural underserved patients, and that's the LSPAN program. So when we think about CT-based lung cancer screening, I think we have to remember that the clinical evidence, I think, is very strong from the NLST, the National Lung Cancer Screening Trial. But those patients are significantly different from what many of us encounter in clinical life. And I think also, I would point out that in a clinical trial, the patients that we enroll, of course, are managed all the way through the process of that trial, because what they're trying to demonstrate is the efficacy of low-dose CT technology to be able to do early detection for lung cancer screening. And in that sense, the patients who are enrolled, and you do all the informed consent that you do for a clinical trial, patients are then moved by research navigators or the study coordinator all the way through every process. What that means is patients are being called, they're being helped through a process to make sure that we have all of the clinical data that we need to show that LDCT is clinically effective. In my world, what I am interested in is the effectiveness of when we take those evidence-based interventions and put them out into the real world. And nothing, in my experience, gets more real than county safety net hospitals. So in the context of the study that I'm going to talk about, I wanted to give you a little sense of Parkland Health and Hospital System in Dallas County. This is our county safety net that provides care for all the underinsured residents of Dallas County through a medical assistance program. So in addition to commercial insurance, Medicare, and Medicaid, the County of Dallas actually has a charter where the health and hospital system doing business as Parkland is responsible for providing care to every resident of Dallas County. So what that means is we function in effect like a safety net Kaiser, if you will, where we are in effect an HMO at the county level for all the residents of Dallas County. They are, of course, eagerly interested in trying to sustain guideline-based care. And so when low-dose CT was first approved, they really were interested in developing a systematic protocol to roll out lung cancer screening as standard of care in primary care settings across the system. Parkland is anchored by a tertiary care hospital, which you see our bright new shiny building, because of course, if it's going to be in Dallas, it has to be bigger and better and shinier than everything else in the world. So we have an enormous 980-bed tertiary care hospital. But what is significant about Dallas County's system is that as an integrated system, that hospital is connected to 12 community-oriented primary care clinics, women and infant clinics, as well as pediatric clinics that are based and co-located in the Dallas Independent School District. And so we have a fully integrated system where those primary care settings across Dallas County are feeding into a tertiary care medical center linked by a common EPIC, in this case, EHR, across the system. So what we tried to do in setting up standard of care was really do some meaningful stakeholder engagement that enabled us to launch standard of care screening in the spring of 2017 with a little bit of a run-in. I just want to give you here what I think of as the feather diagram. So we had two phases of project initiation, project development, and then project implementation. And we're looking across from February in 2016, all of our preparatory work, all the way through to the spring of 2017 when the first patient was referred. My goal in driving this process was to make sure that we could help convene all of the different parties within the system to be able to make these things happen. So there were several key decisions, but we also coupled that with the kind of structured observation that my QI team could conduct to really understand what workflow processes might look like in this system. And needless to say, I think you'll all sympathize, a number of meetings that really needed to happen across the system with our key stakeholders. So starting out on the left, we initially framed the introduction of guideline-based screening through the Primary Care Forum, which is a system-wide biannual event that brings together all of the primary care providers and their clinical teams to talk to them about the fact that the NLST trial had been conducted, to walk them through their outcomes and understand the generation of the guidelines for evidence-based screening. We were particularly interested in trying to work, because of the EPIC system, with Parkland's data team and starting that conversation about how they could build in the lung screening module for ordering, for doing referrals and orders within the EHR. And we worked simultaneously with the QI evaluation team to help them understand what opportunities there were to move this forward so that they could meet all of their metrics. Primary care settings really vary across Parkland, and so we're talking about both family medicine resident clinics, because Parkland is our primary teaching hospital, and we didn't want to leave out the residents within their settings, but the primary focus was on primary care in the community-oriented clinics, where the physicians and all the other providers are direct employees of the county system. This is just a mock-up of our patient flow through the Parkland lung screening process, which we've adapted from my colleagues' work here in articulating the colorectal cancer screening process. But what you'll recognize in the three long boxes is that basically patients need to move through an entire screening process. We know that screening is not effective if you can't follow up on your abnormal results. There's no impact on mortality or morbidity if all patients do is get screened and nothing happens after the initial screen. So moving from the left to the right, we're talking about risk assessment to identify the risk status of these patients. So for example, the 30-pack year history, which I'm sure you're all familiar with, and age over 50, which is particularly relevant, I think, also in recognizing that there is a decade-long window of patients who are eligible where they may not have yet triggered their Medicare coverage at 65. And so a system like Parkland is particularly interested in being able to identify those patients and then map their process to also include their understanding of financial eligibility. So you move through the process in the decision to screen. that's anchored by a shared decision-making visit with a primary care provider in this case, to follow CMS guidelines. The orders placed and appointments are scheduled with radiology. You get into this detection or screening procedures for low-dose CT. You have an outcome of lung rad results in the middle. And then depending on acuity of your lung rad result, they either circle back to additional screening, or if it's a suspicious outcome, we move on to the referral to a lung diagnostics clinic, thoracic surgery, or the pulmonary clinic. There's diagnosis and follow-up with 3 key additional procedures: diagnostic CT for the chest, PET or tissue sampling, and other diagnostic tests, and ultimately to treatment if in fact we do identify a cancer. The key distinction in the shading here is just to look down at the legend, is that there are types of care procedures, but the key is to recognize that for every step that a patient needs to move through, there is an interface required, which is the exchange of information between parties and the accompanying responsibility for moving that information through the process in order to enable the patient to move from risk assessment through screening and diagnosis and follow-up to treatment as necessary. You'll be familiar with the eligibility criteria, so I won't go through them in greater detail. What I just wanted to show is that when we're thinking about these key elements that we wanted to carry over into the electronic health record, we needed to be clear with our providers what those criteria are, and then make sure that they're easily communicated. So what does lung cancer screening look like for providers within the Parkland system? Our EPIC order set asks about smoking history and timing of quitting. For example, if they're a former smoker, to establish their eligibility and PAC history. The EPIC order set includes the documentation regarding CMS required counseling, and the order set triggers the referral to the study team. In my case, we'll talk about that in a moment because that referral is for our RCT. And for standard of care, of course, what we're talking about is the order set triggering the screening CT order that goes out to radiology. All screening CT results include findings, impression, and recommendations, and I'll show you what that looks like. But the call-out box there, for example, is the finding of the radiologist. It is probably benign. Short-term follow-up is suggested, includes nodules with a low likelihood of becoming a clinically active cancer, category 3, with a recommendation of a 6-month LDCT. And the goal is to be able to incorporate all of this into the EHR in a timely way, that providers are able to focus on the idea that they need to introduce screening to the patient, make that referral, and then we wanted to ensure that the system of information coming back to the primary care physician gave them exactly what they needed in a standardized and systematic way so that they could immediately act on telling the patient what they needed to do next. So what I want to show you here, this is just tiny, but to remind you of the categories of lung rads. Based on the NLST outcomes, if you look to the right, what we were expecting that when we established standard of care, 90% of our patients would have a result of their CT scan with a lung rads that needed continual annual low-dose CT next year, continue to that annual low-dose CT. Only about 5% would need additional work of an LDCT within 6 months, and less than 5% would need an LDCT in 3 months or a diagnostic chest CT, the PET CT, or biopsy to follow up on a suspicious finding. And the goal is that those lung rads provide a standardized guidance on all CT screening results, very similar to what you would expect, for example, from mammography screening, which is much more established here and everywhere else. What I want to pull out for you here, this is a excerpt of the actual text coming back from radiology, accompanying the scan results. So you'll see at the top is the findings from the radiologist, going through the lymph nodes, mediastinum, the lungs and pleura, and the abdomen, providing a key impression, and then standardized text identifying the lung rads category with the recommendation for follow-up as above. So here we have a lung RADS category 2, which is the benign appearance, very low likelihood of becoming cancer. This next case, I just wanted to pull you down to show you the lung RADS category 4A of a suspicious finding with recommended management and their follow-up. Important to sustaining attention to new standard of care, our team provided quarterly reports to the leadership team for adult ambulatory medicine with biannual reports back to the primary care forum that I introduced when I talked about our stakeholder process. So that what we're doing is taking these results both to the leadership of ambulatory, for example, all of the lead physicians for the primary care settings meet with the director of adult ambulatory medicine, and we can give them a snapshot on a periodic basis, so they're getting monthly reports. But we're also speaking to the, as you would rank and file, primary care physician in the primary care forum, as well as their clinical teams in those biannual reports. So the next couple of slides are taken from that quarterly report mechanism. And I just want to show you what we're looking at here is not only showing the monthly rate of orders placed over time, and this is from our most, this would have been from last March. So we're looking at all the cumulative orders over time. But we wanted to show the orders placed by each primary care setting over that same time period. So we can call out our champions. Blewett Flowers is primarily an African-American serving clinic. The PCIM is the Parkland Center for Internal Medicine, which is our residency clinic. And DeHaro is a community-oriented clinic for Parkland that's primarily serving a Hispanic and Latino population. And what we're trying to do here is leverage a sense of competition and awareness of to anticipate when primary care clinics feel that they have challenges, they know that their neighbors may be already surmounting that, and we can create a sense of awareness overall. Importantly, what we also did was report the top ordering providers to give a direct sense of the leaders within each clinic for the orders that were placed. And we're doing special recognition at the primary care forums to keep this new standard of care on the radar and help model the kinds of behavior we want in making sure we're identifying eligible patients within each practice and fostering those referrals to guideline-based screening. This is an overall view of CT screening for the lung cancer report by outcome. And so what we see over time is there's a drop in lung cancer screening. So prior to the establishment of standard of care, there was always the opportunity to do a CT order for opportunistic lung cancer screening. So it was not that the order was specifically for screening, but they could use the CT modality and indicate that it was intended for screening. And what we see with this black dotted line is the drop in off-template use as there was uptake in using the template. What we're looking at, the bands here are the relative proportions of lung RADs 1 through 4. And as you can see, as predicted, the levels of 4A suspicious and 4X suspicious are quite small. The vast majority are lung RADs 2, a benign appearance or behavior in the green, with some uncertainty around lung RADs 3 that are probably benign that require additional follow-up sooner than the annual CT that's recommended. We provided key contacts at each report and each presentation in 2 ways to help lung cancer, to help providers recognize that they can reach out for questions about scheduling and billing and the actual CT procedures by connecting primary care directly to a champion within radiology. And if providers had questions about the actual radiologic findings, we could direct them directly to a radiologist focusing on thoracic work, in this case, Dr. Kandatil. From the perspective of the primary care forum, we were we wanted to present our data to date at each opportunity and then engage the providers in the kinds of questions that they might have about their experience to date. The barriers that they think they're encountering to ordering, for example, are they having challenges in navigating the EHR, scheduling those results and referrals? What were their patients' reactions to the introduction of standard of care screening? And importantly, we created an opportunity for them to give us feedback. So a number of primary care settings told us quite early on that they would really like to see a best practice alert, as opposed to recognizing that they need to think about screening within the context of health maintenance overall. So one of the challenges, as you would imagine, is that your presenting patient has a number of issues, particularly in a safety net population of multiple chronic conditions. And so the idea that preventive maintenance is going to float to the top was a challenge for them. And they wanted us to consider and give feedback to leadership that perhaps a best practice alert was necessary and would help them. So we were able to take that information back and give data to the health information management team and the CMIO to think about implementing a best practice alert, which we're actually launching this season. So before I transition into our annual outcomes, I just wanted to ask if people had any questions at this point. Okay, let me walk through. Danielle and Jessica can interrupt me if we've got questions I need to answer. But we just had the opportunity to report our first year of standard of care data at the World Conference on Lung Cancer in Toronto. So let me walk you through these outcomes. Over the course of the year, so these are data from 2017 to 2018, the system was able to refer 844 patients to lung screening. 208 were actually ordered, 40 were canceled, and 68 remain to be scheduled. So at the time, so we have a completed number of 528, or 62% of our patients who had a screen actually completed it. About 52%, as we expected, did not require follow-up procedures and would move on to the second annual. Of those who did require follow-up, only 5 needed to go on to the CT-guided angiography. Only 3 needed an actual biopsy with CT guidance. 168 did require further CT or MR imaging, and 73 were referred to a chest X-ray. What I was excited about here is understanding that it seems like the expectation we had from the NLST bore out and the Parkland population, and I'll show you some additional detail there. This is our table of those completed. So the 528 scans that were actually completed compared against the 316 which were not, of our total 844 orders placed. The only statistical significant difference was in age. And what we found was that there was a slightly higher increase of actually completing your order the older the patient was. And so we're investigating what that compliance implication might mean. I think this is a hideous slide, but I will, if you will bear with me, what it does is adopt, quite simply, the stoplight principle of a dashboard. So our LungRad scores overall suggest that very few patients would actually require invasive procedures. And you can see that the vast majority of our orders resulted in LungRads that are getting a green light to go ahead. And we have some increase in our suspicious lesions. This was important because it helped our providers who were initially concerned that in recognizing the significant communications we've had about the impact of smoking on lung cancer, they were worried that in establishing standard of care for so many patients that we'd have an enormous downstream effect of follow-up for suspicious findings, when in fact we actually have data that is quite close to the NLST projections we would have imagined. So if you think about the implications of standard of care where we don't see failure, or where we don't see an overwhelming burden of patients needing extensive follow-up of suspicious lesions, we do have some key questions about the number of orders placed versus the patients who actually complete their screening. So the question that's raised coming off of the NLST is, what if underserved patients who were not represented in the NLST and did not have the controlled conditions of being moved through a research trial for the efficacy of LDCT, if in the real world, do underserved patients need more help? So after establishing standard of care, Dr. Gerber and I were in a position to propose a randomized control trial of patient navigation. We were proposing to evaluate this intervention among a sample of 340 individuals who had been referred for low-dose CT screening within the Parkland system, with the aim of comparing rates of completion, comparing changes in patient-reported outcomes, and exploring whether differences in those outcomes are moderated by patient attitudes and beliefs. Our goal was to enroll 340 patients from the standard of care pool over a process of 18 months, and I can say that as of today, we have exceeded our enrollment. We were a little concerned about the patient-reported outcomes, and so we've actually extended our accrual to about 450 patients, just to ensure that we don't have loss to follow-up for our surveys, which I'll talk about in just a second. Our eligibility criteria followed the USPSTF guidelines for age and smoking criteria, so that again is the 30-year PAC history. And we restricted in our patient population, at least for the trial, the ability to speak English or Spanish, and we ensured that our navigators were bilingual. And patients were randomized to usual care or to navigation. And again, the outcomes that we're interested in are adherence, patient-reported outcomes, and of course, tobacco use. So if you look at our flow chart, we're enrolling patients. There's a baseline phone survey prior to randomization, and then they're assigned to one of the two groups, usual care or usual care plus navigation. And I will just say that usual care in an integrated safety net, we assumed that standard of care processes might be adequate for patients to move through a process. Indeed, in that sense, low-dose CT screening is no different from any other kind of process that requires movement of patients from primary care to specialty care and back. But the key question was whether, based on the NLST, our patients might need more than usual help in navigating a new process. And indeed, was the organizational process that we had established for standard of care adequate to moving patients through those markers? Our study uses a follow-up phone survey at 6 months with recruitment to interviews from those phone surveys. So let me just take that baseline phone survey, follow-up survey at 6 and 18 months with subsamples of interviews from each arm at the 6-month and 12-month arm. And let me talk a little bit more about that. Aim 2 that talks about patient-reported outcomes is intended to elucidate our group differences. For example, satisfaction with care, quality of life, psychosocial distress, and smoking cessation of moving through the lung cancer screening experience. And we're using both quantitative and qualitative methods to do that assessment. We had hypothesized that patients in the navigation group would report enhanced psychosocial well-being, for example, higher scores on quality of life, greater satisfaction with care, and lower distress, and report higher rates of point prevalence cessation than patients in usual care. The measures we used, if you're interested, are the patient satisfaction with navigation logistics survey. It's a module that was pioneered in lung cancer, in cancer screening. The quality of life measure is our SF8. The anxiety and depression measures you'd be familiar with are the GAD-7 and the PHQ-8, and tobacco use from the NLST questions from the trial. Our surveys are conducted in English and Spanish. And we would hypothesize overall that patients who are being interviewed would report more positive experience with the lung cancer screening process when accompanied by patient navigation. We wanted to assess our attitudes and beliefs using the lung cancer screening belief scale, which is adapted by Carter Harris's team, as well as our semi-structured interviews. And I've just pulled out some examples from the lung cancer screening belief scale here around their ideas to understand if the education intervention that's happening in standard of care between the provider team is actually having an effect, and whether that can be augmented by in the arm for patient navigation. Sorry. And so that's just the exploratory aim, to look at navigation intervention effects and whether they're moderated by theory-based patient attitudes and beliefs adapted from these scales. Our screening endpoints are completion of 3 steps, which we structured conceptually in this way. Steps 1 and 2 and 3 are occurring over varying timeframes for each patient, so that normal or low suspicion scans are repeated annually. Interval scans to evaluate indeterminate CT scans are being performed at intervals less than 12 months, with subsequent steps to evaluate high suspicion CT scans anticipated within weeks of that initial CT scan. The characterization of suspicion, low, indeterminate, or high, reflects the size and imaging features, for example, speculated or calcified, and the rate of change of nodules between the 2 scans. Follow-up of abnormal scans, for example, biopsy or PET-CT, would be determined by the local test availability and the practice patterns, in this case, tied to lung-RAS reporting. Some of the key challenges, of course, is that within the context of the real world, we wanted to be able to differentiate between the controlled circumstances of the NLST and what we were trying to do at Parkland to assess the need of patients for additional navigation. So we are defining navigation in a research context, and I'll talk a little bit about that. We wanted to adapt our measures to capture patient-reported outcomes in our systematic way, and that those were appropriate and equivalent information in both English and Spanish, given our patient population, so that we could maintain scientific rigor, but also monitor and adapt our intervention over time, given the needs of the Parkland system. Among a safety net population, the follow-up of abnormal cancer screening tests tends to lag far behind other integrated health systems like Kaiser, and we wanted to be able to track that, particularly given potential shifts in how the system decided to adapt their standard of care, which we as researchers conducting the trial did not have control over. So this is our patient navigator process, where navigators are making systematic contact with patients at initial intake, with a reminder call 2 to 3 days prior to the appointment, and a follow-up call 3 to 7 days after their scheduled appointment, as well as outreach calls, which were to be triggered by subsequent screening or diagnostic orders. Our navigators were trained using an abbreviated curriculum, about 20 hours, adapted from the George Washington University Cancer Institute. We also gave them a little bit of supplemental training on motivational techniques and the behavioral aspects of lung cancer screening, particularly focusing on smoking cessation and modalities from the School of Public Health in Colorado, and patient resources specific to our county system. What we've found so far in our of the 340 patients that we have moved through the system, we're just presenting this in the next few weeks at the Association of Oncology Nurses and Patient Navigators, where we looked at 305 barriers that had been discussed by the patients. So we developed for our study a database, an interactive database that the research navigators are using by telephone to reach each of these patients, where they're capturing the issues addressed by each of the patients brought up in the context of those reminder calls and follow-up calls, where our navigators are moving through an algorithm of the key issues they want to be able to remind a patient of where they are in the process, what their next step are, empower them to talk to their providers as they move through their appointments from primary to specialty care and back. And of the 305 barriers discussed, what you can see is that while the largest percentage were personal barriers, as opposed to provider barriers, such as concerns about where the provider was located or whether, in fact, the provider had discussed smoking cessation. Patient motivation to complete our screening appointment really varied. Many patients emphasized competing demands, including their prevalent diagnoses, so their presenting issues, and of course, limited transportation options. One of the most common barriers brought up by patients was the lack of knowledge about the appointment date, time, and location. So very pragmatic and logistical issues that the algorithms of our navigators were able to help them with. We found overall that our average call times for outreach were about 13, nearly 14 minutes. Our reminder calls were significantly shorter at 6.2. Our follow-up calls, again, follow our outreach, but are all significantly shorter than our initial intake call. The substantive length of all of these calls, in part, are because the navigators are following their algorithm that, in addition to providing the sort of care coordination of the logistics of moving patients from where they need to go for their next step, was to continually bring up the question of tobacco cessation, reiterate the importance to the referring provider that the patient, if they are a current smoker, endeavor to quit. And the navigators are following a protocol to assess whether or not the patients are willing to quit, thinking about quitting, and moving them to that next step, and then making that referral to tobacco cessation services within the system. So I think that our trial is relevant because, particularly in an era of significant cost constraints, we need to understand what information is necessary to determine whether navigation services can strengthen lung cancer screening adherence and the quality of the experience from the patient perspective. And indeed, I think the sustainability of a population-level adoption of CT screening really will hinge on the capacity of a health system to move patients through completion of all steps. It is a complex process. And as I had indicated, we all know that lung cancer, well, screening in general is not effective if you cannot follow up on abnormal results. And in this case, I think our trial is designed to capture 3 steps that includes patients who are moving, who have a low lung RAD score and only need the annual follow-up, as well as patients who have higher scores with the likelihood of a suspicious finding, and then we're measuring those interim steps at the same kinds of completion so that we have comparable metrics of adherence across the acuity of the lung cancer screening outcome. And I just want to stop here before I shift to talking a little bit more about navigation for any questions.
Yes, hi, Dr. Lee. We had a couple of questions. So we had one mention that that person has had some resistance from a few PCPs in regards to lung dose CT, and wondered if you had any suggestions that would be a good way to address that with them.
So we tried, our initial approach was to make sure that this was a multidisciplinary effort represented by the whole system so that we could have radiologists on hand to be able to discuss the implications of doing specialty referrals for additional procedures and orient them to both the data from the NLST trial, but also to build the analogies to help them understand the ways in which low-dose CT screening was comparable to other kinds of standard of care screening for different disease modalities like mammography. I think one of the key challenges was trying to be able to understand what are the implications. Providers, I can't speak to provider concerns about the efficacy of the LDCT. The trial was quite definitive. I think the important thing that resonated with our providers was that prior to low-dose CT screening, there really was no way to identify lung cancer early. So we have consistently, and particularly in a culturally diverse safety net setting, the lung cancer cases that we were identifying at Parkland were almost uniformly stage 3 and 4 lung cancer. One of the key things clinically that I think providers are very frustrated about with the question of lung cancer screening is the lack of specificity in patient-reported symptoms for lung cancer, because the tissue do not have pain receptors, and because many of the markers of that could signal lung cancer are pretty ubiquitous to anybody who has lung challenges, things like COPD or asthma, or high rates of both, seasonal rhinovirus as well as things like flu, where any of those issues are really undistinguishable. And so there's a lot of concern about false referral, but CT really gives us the opportunity for a minimally invasive procedure, in fact, non-invasive procedure, that's easy for patients to do in the sense that it's just a short breath hold. So it's comparable to going through established, most patients are familiar with the idea of getting an X-ray and can understand what low-dose CT is really going to be like. So the idea for uptake is there. And what we tried to really emphasize was the opportunity here to intervene early in identifying patients where we could actually refer them to lung cancer treatment quickly and, in fact, move them through a curative process, where the burden of lung cancer at Parkland had definitely been late stage, and I think there was really significant concern there. Does that get at the question?
I think so. Mark, you can certainly respond if you have any other questions in regards to that. And then we had another one, which I think you already answered. Mark said, yes, you answered that question.
Okay.
Absolutely. And then from Dan, he had asked about hearing about the navigation interventions themselves. And then you went into what those steps were in the call process. So I believe that you answered that question as well. And Dan, please feel free to state if that question was answered appropriately. And other than that, we're all set to move forward.
Okay. Well, and I think Dan brings out a good point. What I failed to emphasize in the beginning was one of the things that we had tried to protocolize in our navigation was we knew that in a in a dispersed system where the community clinics are spread out across the county, patients are all coming to one central radiology site near the tertiary hospital. We knew that the idea of adding a navigation visit, a face-to-face encounter, would actually create would increase the complexity of the screening process. The challenge for our patients is that they're being seen episodically in primary care. Many of them have multiple chronic conditions, so they're also seeing specialists if they have exacerbations of those conditions. The idea of adding an additional visit was going to be more complicated. So what we had anticipated was the need to make this telephone-based patient navigation. And I think what I'll do is move forward, because I think that the implications of that for telemedicine are important for thinking about how we might adapt this to the rural program.
Great. And Dr. Lee, one quick other question that's pertinent for right now. Were the navigators located at the radiology site or with the PCP was the question?
So they're neither. They're actually based here as research navigators. So they're making telephone calls. Mm-hmm. So the entire process is a database-driven telephone call, so that they don't need to be housed either in primary care or in radiology. They're basically reaching the patients at home. Great.
Thank you.
So one of the key challenges when we talk about patient navigation is there are a lot of definitions of what that really means. And this gets to the question that Dan raised, where we need to think about who's actually doing this work and what does it mean that they are doing in order to understand what efficacy looks like. So the key issues for navigation are helping patients move from step to step. And so there are the usual issues of the social determinants of health that are both barriers and facilitators to completing steps within a healthcare system. One of the challenges for protocolization is that in many cases, the very motivated navigator may adopt a more case management approach. And that, I think, was what I was getting at with the National Lung Cancer Screening Trial, is that within the context of a study, they're taking each patient, each participant in the trial, and adopting a case management approach of whatever the individual challenges of a patient are, we are going to get them through this process. That's not really feasible if you're trying to scale it up out of a trial and into a real world system. And that's why we pushed for a more algorithm-driven process where navigators would follow a predetermined process and we could determine the dose of what the navigator was providing to the patient. In the work that I have done elsewhere, which I'll talk about in the next slide, there are key questions about whether the navigator, the level of clinical expertise that a navigator needs. And so there are models of patient navigation led by nurses or indeed advanced practice professionals versus a layperson approach, more like a promotora model, where the key alignment is about the socioeconomic background or racial concordance with a patient to help them sort of role model the fact that something like screening is, one, relevant to this population, important in their lives, and actually feasible, where the navigator is really role modeling the ability of a patient to move through this process and help them identify why screening is important both to the patient and to their family. I think there's a real range of function in what navigators may be doing, and what we wanted to focus on was the added opportunity to help with tobacco cessation through motivational interviewing. And so while we did not fully immerse our navigators in a full-on motivational interviewing course, what we did do was bring out those key elements of the theory of motivational interviewing and identify what were important prompts to move patients over barriers that they were encountering, to do that level of empowerment and have standardized language so that a patient receiving a phone call from a navigator could get, the affirmation of where they are in the process, affirmation about the challenges they're facing, and then engage in some problem solving, more like the sort of CBT model, to really think through what needs to happen, and always coming back to the role of the navigator in helping patients move through the logistics of the Parkland health system with respect to their personal experience and really do that coordination of care. We focused on the idea of navigation as tasks rather than navigator as a type of person, and that their goal was to really fill in the care gaps of local context. So in the context of Parkland, they have exceptional primary care, but the key challenge in the primary care setting is the high number of patient visits that a provider needs to go through each day. And so was there an opportunity for the navigator to reinforce the key messages that we know were going to be initiated by the provider in making that referral, moving them through that shared decision-making process of understanding what is screening, what does it mean, and the need for active follow-up, and to help the navigator move that patient along and reiterate that the reason I'm calling you is that your physician, Dr. Bob, has made this referral and would really like to see you after you've had your scan to talk about your results, and link that back to the provider endorsement. Particularly, I think, of relevance for this audience is the question of small-scale community partners, where many of our clinics are resource limited, plus there's the added geographic dispersal of patients. And I alluded a little bit to that in terms of the breadth of Dallas County and moving patients through the system where they're moving from their primary care clinic to central radiology. But I think that's a good point of departure to talk about my work in adapting this for a rural setting. So our partner in UT Southwestern, so if you look at this map The dark navy Tarrant County is just to the west of Dallas County, where Moncrief Cancer Institute is our community partner. And what we were interested in doing was adapting our work at Parkland for the more decentralized model of trying to provide care to patients in rural communities, particularly those who are underinsured. And so we developed a program called LSPAN, or Lung Cancer Screening and Patient Navigation, that adopts a decentralized model I first developed in my breast cancer screening work in order to provide service across a large geographic area. In this context, we're looking at a set of counties in North Texas that are about 13,000 square miles, roughly the size of Connecticut and Vermont combined. This is predominantly rural and ranching communities that are either full or partial medically underserved or health provider shortage areas. We have about 47,000 screen-eligible patients. And in this funded study of evidence-based programs delivery, we're expecting to provide screening for about 2,500 patients. The median per capita income in these communities is about $26,000, with nearly 16% of the population living at or below federal poverty levels. 20% of the population is uninsured, 27% are underinsured or enrolled in Medicaid, which I probably don't need to tell you, in Texas is an extremely tight federal-state partnership with very stringent eligibility criteria. And even if you are eligible, not particularly generous benefits. It's largely most effective for mothers with small children. Smoking prevalence is quite elevated, ranging from about 16 to 18%, which is several points higher than the national average, which I think hovers around 14 and 15%. 60% of this catchment area are non-Hispanic white, 25% are Hispanic, and only about 12% are African American. Based on my breast cancer screening work, what I know in these counties is that in contrast to what the census might tell us, 48% of the patients that we were seeing, so under and uninsured patients looking for cancer screening, 48% self-identified as Hispanic, and of those, 38% preferred to receive services in Spanish. And I would just signal that as a proxy for recent immigrants to North Texas, which is often an overlooked population for our rural communities, which largely identify as Anglo. So the idea of LSPAN is to mirror the service delivery model we have used at Moncrief that's comprised of outreach and health promotion to reach into rural and underserved communities to identify those patients, delivery and navigation to guide them through comprehensive screening and follow-up care, including the tobacco cessation education and counseling that you would expect, through a model of centralized reimbursement to fund those clinical services through a shared funding model. These components reduce geographic and financial barriers for patients meeting the criteria for lung cancer screening. So this work is supported by the Cancer Prevention and Research Institute of Texas. As a funder, they have two domains. One, which is research, largely focusing on bench science, but also population work, and that's what's supporting our trial at Parkland that I've just finished discussing. Their second portfolio is the delivery of evidence-based prevention programs, and that's what's funding this LSPAN initiative. So the dollars are intended to fund services that are evidence-based in prevention, for example, low-dose CT screening. But we can use those dollars as pass-through in effect because Moncrief is a clinical provider in itself, but it's supported by a community family foundation, that they're interested in providing the umbrella work to pass through service dollars to community providers in order to help local providers in the rural counties serve the patients they would like to serve, but don't have a funding opportunity to do that. So specifically, we're talking about the underinsured and uninsured in rural North Texas.
And Dr. Lee, I just wanted to give you a little time check, about 2 minutes, 3 minutes.
Thank you. We're just sort of 2 slides away, I think.
Perfect.
So just to get into a little bit of detail about delivery and navigation, the team is led by oncology certified registered nurses, but they have physician oversight The goal of the program, however, of course, is that intake is managed so that everyone on the navigation team is functioning at top of scope. But 2/3 of our patients of our team is bilingual. We're recruiting screen-eligible patients from both our existing clinical population, for example, those I've identified for breast cancer screening, as well as community-based providers that are looking to refer patients into the system. Community members themselves can self-enroll by calling a centralized toll-free number and going through their intake with the navigation team. And again, all of that is telephone-based and algorithm-driven. I talked a little bit about the centralized reimbursement schema already. The goal is that CPRIT is providing funds for the fully underinsured, but of course we're navigating patients to ACA or private plans as possible. So those patients who don't have opportunities for other sources of funding are covered by CPRIT. And all of that financial information gathered through intake is in an electronic accounting system so that we can both track our patients and do all the key reporting we need for our program metrics. So all the survivors are provided on-site. All services are provided on-site or on our mobile health unit that's going out to those communities, or through the collaborating local partner. If you remember back to my map, our services are distributed across key brick and mortar sites, and then the counties that don't have that brick and mortar opportunity are referring in. And this only just ensures seamless navigation, resulting in lower rates of loss to follow-up, but also maximizing our resource utilization. At 6 months, the program has now been getting about 10 referrals per week or 40 per month. So overall, we've had 197. And I would show you here just our LANGRADS outcomes are comparable to what we're seeing both in the NLST and in our urban setting at Parkland, with the difference of LANGRADS 4A, where we're seeing about 12% in contrast to the 5% we were seeing at Parkland. Now, these scans are being read by the same faculty radiologists, so we're unsure if this higher percentage is about the smaller numbers or some unknown difference in the screening population that we still have yet to identify. The tobacco cessation component is always challenging, I think, for patients who are dealing with multiple other issues and whether or not they're willing to consider quitting. But of the 118 who did schedule their screening, 41 were ready to quit. We've had some good quit attempts that have resulted in sustained quitting in conjunction with their navigation. But we still have a significant number of patients who are still in their pre-contemplation mode, as well as identifying 48 former smokers. And of course, we have additional support opportunities that we can refer them to within the community, as well as at Moncrief through the LSPAN program. So my takeaway for all of you is that I think that their systematic programs for lung cancer screening can be successfully implemented in our urban safety net setting. I think our decentralized model for rural telemedicine have strong results, but we are not really in a position to be conclusive at this point. We're trying to continue to monitor our completion trends and address those strategies to facilitate initiation and completion among our patients, with the goal of understanding our longer-term outcomes for bringing this evidence-based prevention to really vulnerable populations. I just want to thank my partners both here at Parkland in our Dallas context and our partners at Moncrief in Tarrant, who are partnering with those clinical providers in the outer counties, and of course the support of CPRIT to make all of this possible. I am happy to take any questions.
Thank you so much, Dr. Lee, for this wonderful webinar and sharing this terrific work with us, and very applicable to the rural nature of Maine as well. And so thank you so much. So does anyone have any last minute questions? I know we're a little bit over time, so I know that some of you may have other places that you need to be, and we understand that. We also did put something in the chat box, Dr. Lee, so that you're aware if there were any further questions for them to put them in the chat box, and we can also address them at that time. So we do have one quick question and then we'll wrap that up. And it was, do you have any projection about the increased use of LDCT?
I think we are excited at Parkland because there has been so much uptake within this safety net setting that I think there's real opportunity for us to try and take this across North Texas. So we are fortunate that in Tarrant County next door, where Moncrief is based, they also have a county hospital system that is also integrated similarly. And our goal would be able to help them build up their practice. I think nationally, the challenges really are, I'm hoping that our RCT results will be timely, because I think that many systems and practices have thought about how they might implement, but I think many hesitate because of the challenge for annual screening. We've looked, a lot of our prior work has been in colorectal cancer screening, where it's similar, that if you have patients who are either ineligible, or if you have a risk stratified program where not everyone can get a colonoscopy, which is of course the gold standard, but they're relying on the annual use of FIT to stratify risk, which I think is really the best option, particularly for a low resource setting or for the more diverse populations that are going to county hospitals, that the key challenge is helping patients understand that they need to do the test every year. And I think that's going to be the real rate limiting step, is what settings need to be able to make sure that they can achieve patient adherence to the process. And I'm hopeful that our schema for the 3-step outcomes that work across the range of lung RADS results that people will get will be informative and really help us scale it up into the real world.
That's great. Thank you so much for that question. That's a great question. So just for the sake of time, we do have a couple other questions, but we will be sending that out to everyone, as it is 1:05. So again, Dr. Lee, thank you so much for joining us and sharing your work with us. We are so grateful for your time and this presentation. So again, please know again to everyone, if you think of questions after the fact, again, Danielle put in the chat box where you can email us. We will be in touch with Dr. Lee and we will get those questions out. We will develop a question and answer document that we will put all these questions on and send those back out to everyone, include that with the slide deck and the recording. So thank you all for joining us on behalf of the Maine Lung Cancer Coalition. We thank you for joining us for this webinar, and there will be more to come in the year ahead. So thank you everyone and have a wonderful day.
Thank you.
Thank you again.